Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Saurabh Agarwal from London, United Kingdom. Dr. Agarwal is an orthopedic surgeon based in London, UK, specializing in upper limb surgery. He's triple fellowship trained, shoulder, elbow, hands, and trauma, undertaken at the King's College Hospital in London. He's actively involved in academics and runs his own teaching course for the FRCS candidates since 2012. He's also active in research and has presented at international, national, and regional levels. Presently, he's working as consultant trauma, orthopedic, and upper limb surgeon at the Princess Royal University Hospital in London. If you notice, Dr. Agarwal has delivered several lectures on our channel, and today is my great honor to bring back Dr. Saurabh Agarwal for this wonderful live program. Over to you, Saurabh.
Well, thank you, Hitesh, for your kind introduction and invitation. Good to see you. So I'm Saurabh. I'm an upper limb surgeon. I work at Princess Royal Hospital, London. So I'm going to talk about overview of rheumatoid hand and wrist catered to the FRCSOrth exams. Now I have divided it into two parts because it's very exhaustive. I've also done a lecture on Vaughan-Jackson Lesion a few days back, which is also on Dr. Hitesh's Orthopedic Principles in my YouTube channel. So these are the questions that can be asked. So for vivas is Vaughan-Jackson lesions, capital ulnars, synovitis to the tendons, to the joints, radial deviation of wrist causing ulnar drift of fingers, and then finger and thumb deformities, your swan necks, your boutonnieres, thumb problems. Similarly, in short cases, previous surgery is very much likely because they keep on having operations. So you will be expected to pick up scars and describe them, and the surgery is catering to those scars or the nerve issues. And then again, radial deviation to the wrist and finger drops and ulnar drifts and finger and thumb deformities. And what is more important is how you describe the deformities, starting from proximal to distal. So that itself is a pass. Definition: it is chronic, it is systemic, it's an autoimmune disease, antigen-antibody complexes which attack the synovium and the cartilage, and there's a genetic predisposition. Pathophysiology, again, antigen-antibody complexes, they will cause synovial proliferation, which is also known as PANAS. Then all these enzymes, your collagenases, proteases, elastases, they are the culprits. They are the ones which come and destroy all the collagen, which is in your cartilage, your ligaments. They destroy. So once your ligament and cartilage goes, obviously joint is eroded, then it gets subluxed, it gets destroyed, and a deformity happens. Similarly, they can purely affect the tendon, cause synovial proliferation, and then eventually a rupture. Similar theme, pathoanatomy. So again, in a joint, first thing would be a synovitis with no deformity. So this is the stage. You want to pick up your rheumatoid patients, you want to diagnose them, do synovectomies, start the medicines after liaising with rheumatologist. And then synovitis ultimately causes a deformity, which is again passively correctable. So this is a time you can do soft tissue procedures. Then the deformity gets fixed, but still there are no erosive changes. And finally, cartilage gets destroyed, and this is a stage of no return. So remember these four stages. Then the diagnostic criteria, this is the one we are using in London, Europe, or America also. I'm sure this is the one used everywhere. So I will encourage you to have a read of this paper by American College of Rheumatologists. And basically what this paper suggested was, so they created a total score of 10, and they said a score of 6 or greater in these 4 domains equals a diagnosis of rheumatoid arthritis. So they said number and site of involved joints and gave the score. Then serology, this 0 to 3 score. Elevated acute phase response, again, score was 0 to 1. And symptom duration, again with a score of 0 to 1. So if you add all these scores, it counts to 10, 6 and above equals a rheumatoid arthritis. So they concluded, so the whole idea of this paper and these scores was to focus on the features at the earlier stage of the disease. So before that, we used to pick up rheumatoid, but at the later stage. By that time, erosion had started and we had missed the boat, if you like. So the whole emphasis was to do an earlier diagnosis before erosion and then start effective disease suppressing therapy so that sort of those deformities don't happen, those erosions don't happen. So radiology. So these are the things we try and pick up: any soft tissue swellings, any osteopenia, erosions, subluxations, dislocations, loss of joint spaces, and finally ankylosis. So any X-ray given to you, these are the features to describe. So types of rheumatoid, very important to pick up those. So mutilants, as the name suggests, is an end stage, very deformed joints, hardly any function. Then nodular, again, rheumatoid classically presents with these nodules on the skin, either in hands or the forearm or around the elbow. So important to pick up these nodules and describe them. And the most definitive diagnosis of a rheumatoid is to excise one of them and send it to a lab for histopathology. So bring that out in the exam. Osteoarthritis, so remember, once rheumatoid burns out, osteoarthritis can superimpose. For example, this patient has got now Bouchard nodes and Hebden nodes. So remember, rheumatoid can also have osteoarthritis towards the end stages. Same goes for hip and knee. Then soft tissue laxity, self-explanatory. With so much ulnar deviation, obviously the ligaments are all gone. So remember that. Synovitis. So remember, rheumatoid can have synovial proliferations, your pannus, either coming from the joint or just localized to the tendon, which I'll show you in my Vaughan-Jackson, my operative case. So for example, here it seems to be coming from the radiocarpal joint. Something is happening at the drudge. And look at the PIPs to the index and middle finger. So synovitis was the first stage in pathoanatomy. That is the stage you want to be able to do synovectomy, send part of the synovium and fluid for histopathology, of course, do the cultures, histopathology, to be able to pick up rheumatoid, liaise with your rheumatology colleague, and start the treatment. Then ulnar caput. So what is ulnar caput? So again, like with any joint, when rheumatoid attacks DRUJ, so if I draw your attention to the bottom right picture, then your ligaments start to erode. So once your volar DRUJ ligament erodes, ulnar head will tend to sublux or dislocate dorsally. So as you can see, ECU has come off his groove and is tending to relatively sublux volarwards. And that's why it's the EDM, which is where the problem starts, which is where the rupture starts. So that's caput ulnar. This is how it will look on an X-ray, very prominent eroded ulnar head. And this is how it look clinically, very prominent ulnar head. No wonder this patient will, no surprises, this patient will end up having a EDM rupture at the least. So how do we assess a rheumatoid patient? Because the assessment in a rheumatoid is very different to the assessment in an osteoarthritic patient. And then how do we plan the surgery, the principles, the options, the results? So key points will be assessment, your MDT approach, bring this out in the exam, and surgery will be all about the principles, the options you have, and finally the results. What does the literature say? So assessment should be in all these parameters: functional, anatomical, radiological, psychological, medical, and then surgical assessment. Functional, of course, this is where your hand therapist and your occupational therapist help you to see what function they're able to do. So sometimes the patient may have a very marked deformity, but functionally they are okay, they're coping. So they're not the candidates. So deformity doesn't mean this patient needs a surgery. So assessment is important. Anatomical, we've spoken about nodes or nodules, then skin condition, previous scars. So all those are very important in planning your surgery. Radiological, so again, mutilants we've spoken about. This is completely, this is an end stage, lots of erosions, lots of osteopenia, deformed joints, hardly any space left, as opposed to rheumatoid robustus. So what this term means is, patient has rheumatoid, But if you like, there are hardly any clinical features. So they live with it, but the joints are not destroyed. If you can see MCPs, even radiocarpals, your carpometacarpal joints. So this X-ray doesn't have typical features of rheumatoid. And clinically also, patients do very well. So remember this term, robustus. So X-rays are important. Psychological, very important, because lots going on all over their body. So your psychotherapist is your good friend who's going to talk to them about their behaviors, emotions, and thoughts. So involve psychotherapists if needed. Medical comorbidities, because they have a different set and peculiar set of comorbidities, if you like. So the vasculitis, the heart issues, the lung issues, splenomegaly, Still's disease, Sjogren's syndrome. So these are all the associations. This is where your rheumatology friend comes into being. So your multidisciplinary approach. So this is a buzzword, bring that out in the exam. So always, anyways, they had seen rheumatologists, but you must read their letters, you must talk to them to get an update. Medical, again, the drugs they're on, are they on anti-TNF? Are they on methotrexate? Because if you're planning a surgery, then anti-TNF needs to be stopped through few weeks prior and few weeks after, till the wound healing happens, because they can hamper wound healing. And these patients are immunosuppressed. So wound healing problems, infection issues. So MDT approach is very, very important in a rheumatoid patient. So you as a surgeon, your rheumatology friend, your hand therapist, and your occupational therapist who's making all these splints and doing changes to their home environment. It's all very important. So indications for surgery, self-explanatory, they have pain and it's not responding to the drugs. So the deformities and the pain that they have is affecting their daily activities or their work or their hobby, and the deformity is progressing because clearly the drugs are not working. So this is the time you would like to intervene. Aims of surgery. So like with any surgery, you would want to relieve their pain, restore the function, prevent further damage, and cosmesis is important. So remember, they come with very deformed digits. So if you improve the cosmesis, sometimes that itself is very helpful for their psyche, for their motivation. So remember cosmesis, it is important for a rheumatoid patient. Principles of surgery. So remember, as I was telling you before, deformity does not mean an operation. Patient may have finger deformities, but they're doing very well in terms of function. Their functional demands may not be that much. They may be 75 or 80. So every deformity doesn't equal an operation. And then tailor your approach to each patient. So look at the whole patient, all their issues which I've discussed about. Very important, their needs. Every patient's needs are different, and their expectations from you as a surgeon. Look at the other joints, their hips and knees, atlantoaxial joint, neck joint. And then you have to see how much functionally you can improve them versus their needs. That's very important. Needs are more important than what functional improvement you can bring about. Equally, at the same time, remember, a little someone with nothing is a lot to them. So if you can help them even a little, that means a world to them. And then, of course, a detailed clinical assessment, as we've spoken about, social assessment, as we've spoken about. This is where your occupational therapist and hand therapist comes into picture. In fact, they play a bigger role than you do as a surgeon. And of course, liaise with rheumatologists. Be optimistic, but realistic. You cannot make the wrist normal after surgery. You can convert a deformed, painful wrist into a functional wrist. And then, of course, start from proximal to distal. So start with the wrist, then go towards the digits. And remember, these patients are there with you for your whole life because they will always have the need for something or the other. So to gain their confidence, start with the winner. Start with a surgery which will help them, and that sort of helps you to gain their trust. So what are the options that you have? So simple synovectomies, as I've told you before the erosive stage. That's where you want to do your synovectomy and histopathology. Tenosynovectomy, so for tendon synovial proliferations, tendon surgeries, so any tendon ruptures, you want to do your tendon transfers or grafts. And then, of course, in the end stage, deformed arthritic digits or wrist or any joint, either arthroplasty or arthrodesis. So again, just to recap everything. So remember drugs, they'll be on loads of drugs. So some of them need to be stopped. So liaise with the rheumatologist. Anemia, so hemoglobin is low, you have to deal with that. Infection risk, poor wound healings, sinus formations, then neck, that's where your anesthetic colleague comes in, C1, C2 instabilities. And chances are they will have some surgeries in the past. So you have to have a holistic picture before you offer them any surgery. So let's look at the surgical priorities. So these are the 8 things in hand and wrist. So nerves have to be addressed first, followed by flexor tendons, then the wrist, then the thumb, MCPs, extensor tendons, then PIPs, and last are the DIPJ. This is an important slide for exam purposes, because if they have 3-4 existing problems, you will be asked the surgical sieve as to how you will prioritize. So let's look at them one by one, barring the digit deformity. So I'm going to not talk about thumb, PIPs and DIPs in this lecture. That will be a separate lecture, which will follow this in next few days. So nerves. So these are the potential nerves in upper limb which can be involved. So let's look at the carpal tunnel. So 9 tendons here, 4 FDS, 4 FDP, 1 FPL. Remember, if they get flexor tenosynovitis, it becomes a space occupying lesion. Median nerve will get compressed. So offer them a carpal tunnel release and flexor tenosynovectomy. Similarly, cubital tunnel behind the elbow, if there's any synovial proliferation from the ulnohumeral joint, it will involve the ulnar nerve. So you have to go in and decompress the nerve and get into the ulnohumeral joint to remove all the synovial proliferation. Always use the opportunity for a histopathology. Guen's canal, so at the wrist area, again, if there is a synovial proliferation from the joints or from the FCU tendon, it can compress the ulnar nerve. Depending on the zone, there will be varying symptoms. The idea is to decompress the Guen's canal. Radial nerve, so this time the culprit is the radiocapitellar synovitis in this area. So again, that's why the pin will get involved. So again, an ultrasound or an MRI, and then if you're sure of the diagnosis, then deal with radiocapitellar synovitis. Otherwise, you can do a whole pin release in the supinator muscle through a Green's type of approach. So next priority will be flexor tendons. So there are 2 tendons to think about, your FPL to thumb and your FDP to your index finger. So what happens is, so if I draw your attention to this axial cut, so scaphoid again, if it gets eroded, this will result in this osteophyte. It will erode through the floor of the carpal tunnel. And as you can see, it's going to first erode or attack the flexor pollicis longus. And then, of course, it can go on to attack the FDP to the index finger. Similarly, if there's a erosion to trapezium and an osteophyte, it will do the same. First the FPL and maybe then the FDP. Now, this is known as Mannerfelt syndrome, and this is how it manifests. On asking patient to make a fist, thumb stays hyperextended because FPL is gone. FDP is flexing, so in this patient, it was only the FPL. Now the differential would be the anterior interosseous nerve. And remember, if it's the nerve involvement, so tendons are intact, so the tenodesis effect will differentiate them. Tenodesis effect works on the fixed length of tendon. So if you ask the patient to flex the wrist, so the thumb and the index finger will flex. And if you ask the patient to flex the wrist, thumb and index finger will extend. So it's the flexion of the wrist where the thumb and index finger will flex, whereas if the tendons are ruptured, i.e. Mannerfelt syndrome, they will not flex on extension of the wrist. So remember Mannerfelt syndrome and how you differentiate it from AIN nerve palsy. So that's your flexor tendons. And the third priority will be your wrist. Remember, proximal to distal. So wrist, MCPs, PIPs, DIPs. And then in between, think of your thumb and your extensors. So let's look at the wrist. So what happens at the wrist? Carpus tends to drift ulnarwards. With the result, wrist will radially deviate, and then the fingers will ulnar deviate. And you may be asked the reason for this. So lots of reasons. I've highlighted some of them in red. This slide will be there on my YouTube and Dr. Hitesh's orthopedic principles. So you can read them at your leisure. But yeah, few reasons. For example, direction of the pull of extensors and flexors. So because extensors, as you can see, tend to drift ulnarwards. So yeah, they are going to pull the finger ulnarwards also. Then with gravity, wrist will tend to go radialwards and finger ulnarwards. And then force of opposition from thumb onto fingers. So as I make a pinch, I'm pushing the fingers ulnar side. Then of course, attrition of the radial collaterals. So if the radial collaterals will go, fingers are going to go ulnarwards. Extensor tendon subluxation in the ulnar girdles we've spoken about. And as carpus supinates and radial deviation of the wrist happens, biomechanically, the force of extensor and flexor tendons will start pulling the fingers ulnarwards and wrist radialwards. So remember some of the causes for exam purposes. So how do we manage a rheumatoid wrist? And do remember, as an orthopedic surgeon, I'm discussing the surgical part. Remember, they've already been to rheumatologist, the hand therapist, the occupational therapist, and we are operating on them because none of them has worked so far. They are in pain, their deformity is progressing. So basically, these are the options. Historically, and even now in some places, we do partial fusions. So a radiolunate fusion, which is known as cameo fusion. And then we can offer them an arthrodesis or an arthroplasty. So arthrodesis can be done in few ways. So this is how it was done traditionally, a plate from the back, and it used to span the carpometacarpal joint. These days, we tend to preserve CMCs so that they get a bit of 5 to 7 degrees of movement there. So you can just use any two hand plates or CMC sparing specific wrist fusion plates. And if the bone is very osteoporotic and you feel plate will not or screws will not hold, then you can put a Steinmann pin just from middle finger metacarpal or index finger into the radial canal. And finally, wrist arthroplasty. So in the following slide, we'll see the results of wrist arthroplasty because it's a modern thing. Now, if someone has a bilateral rheumatoid, then what can we do? We can fuse both the wrists, fuse one, replace both. So let's see what the literature says. So arthrodesis has been done historically, and I can tell you because I've done loads of arthrodesis in osteoarthritic wrist and rheumatoid wrist. It does have a very good result. In fact, in osteoarthritis, even better than 90%. In a rheumatoid, good success rate. And this is the paper which I will encourage you to read. But if we do a wrist replacement, so I do offer wrist replacements both for osteoarthritis and rheumatoid. Again, we do have sort of 10-year results now. And again, survival is comparable to arthrodesis, around 90%. But yes, replacement is like more complicated procedure. So it will have higher complication rates. Sometimes tendon can be too tight. In that case, I've had to go in once to revise my wrist replacement to a wrist fusion, but that was done for an osteoarthritic wrist, not a rheumatoid wrist. And remember, if you ask patients with rheumatoids, they do prefer a wrist replacement because you're preserving movements. And movements are very important to them because they have issues right from wrist to MCPs to PIPs to DIPs. So if you can preserve movements, nothing like it. So still sticking to the same theme, wrist. So what do we do for the drudge? So these are the few options we have in our arsenal: a Darex, bars, or a hemiarthroplasty. So hemi you can do, but remember two things. One, drudge, sigmoid knot should not be too arthritic. Second, the dorsal lip of the sigmoid knot should be intact. Otherwise, the hemi will tend to sublux dorsally. Bars, I'm going to show you in my extensor tendon in my Vaughan-Jackson's. Darex is a straightforward sort of excision of ulnar head. Again, I'm not a big fan of Darex. I would do a bars for completeness sake. I put it here. But do remember, sometimes you may have to do directs. In a rheumatoid who's an elderly, more than 65, where the demands are less, the proximal stump impingement to radius will be almost negligible on functional loading. So direct still has a role. And then, of course, you can combine your directs with wrist fusions. And as I said, bars, I'm going to show you later in the slides. Thumb, I'm going to skip because digital deformities I'm going to discuss in my next lecture. The thumb we are skipping. So let's come to MCPs. So again, remember in exam, you can be shown this picture. So your discussion will be on MCPs and finger drops. So what causes dropped fingers? What's the differential? This is an important slide. So synovitis can happen at MCP. So extensor hood gets damaged and your extensor tendons drift in the ulnar gutters. So that will result in dropped fingers eventually. MCP will tend to sublux, as you can see here, ulnarwards and volarwards. Volar plates in the front can contract secondary to all these pathologies going on. Intrinsic contractures can cause dropped fingers. Then extensor tendon ruptures obviously can cause dropped fingers, which is my case today in extensor tendon damage. And then pin palsy. So as we were talking in the nerve section, if there's a radiocapitellar synovitis, it can involve posterior interosseous nerve, which means all the four fingers will drop. So if you are asked to differentiate again tenodesis effect, so in a pin palsy, because of fixed length to the tendons, when I flex the wrist, all my fingers will extend, four fingers will extend. But if there was an extensor tendon rupture, on flexing the wrist, if there were two finger extensor tendon ruptures to the ring and little, they will stay dropped. They're not going to come up. This is how you differentiate. So what can we offer for MCPs? MCP fusion is a very bad procedure because for all of us to be able to use our fingers, MCP are the ones which move first, and they will flex or extend depending on the function we want from PIPs or DIPs. So MCP stability and function is very important. That's why fusion is not a good idea. And we can offer them silicone MCP replacements plus extensor tendon centralization, or we can offer them pyrocarbon ones. Pyrocarbon's problem is they settle, i.e. they cause bone osteolysis, and revising them is difficult. So I still feel MCP silicone replacements, at least in my hands, do well. This is how they look. They're not going to cause bone osteolysis. This is the sort of approach, and they're very easy to revise. And then, of course, centralize your extensor tendons. And finally, we're going to talk about extensors. As I was saying, PIPs and DIPs in the next lecture. So extensor tendon, what you will be asked in the exam is sort of this sort of a patient with this sort of a hand. So someone with dropped fingers, you have to discuss all the differentials with your examiner or in your clinic setting. So two things, carpal tunnel syndrome, was that, as I was telling you before, volar ligaments goes, a lot of erosion to the capsule, ulnar head goes dorsally, and you can see why EDM is the first tendon to go. ECU has its own subsheath and it drops. It's not at where the erosion is, so it's going to escape the rupture. And when tendons start rupturing from ulnar to radial side, it's known as Vaughan-Jackson syndrome. So Vaughan-Jackson cause we have discussed. Order of progression, what is ulnar caput? We've discussed. Then finally, the treatment of your tendon ruptures and treatment of your eroded, enlarged ulnar head. So cause discussed easy to little finger, easy to ring finger, and middle finger is not that EP rupture happens. Down the ear, let's just Tubercle. Then to middle finger, and finally the ED to the index. One finger rupture, EDM, and all the EDMs to whichever number the patient has. A side to side transfer to the intact to ring finger. That's one option. If sorry guys, I think there was a bit of an interruption. So we were talking about the little finger tendon, and we can do a, if it goes, we can do a side
Saurabh,
transfer to.
Saurabh, your slide is not visible.
Oh, I think on my computer it is. So shall I
Yeah,
say
now it's
sharing?
no, now it's okay. Can
Okay.
you go to the previous slide, please?
Yeah, sure. So guys, sorry about the interruption. So we're talking about the.
Saurabh, you can switch off your video because that will increase the consumption.
Switch off my video. Okay.
Yeah.
Stop video. Yeah. So guys, we were talking, sorry for the interruption. We're talking about the order of tendon rupture progression. So, as I was saying, start with the little finger EDMs, then EDM and EDC to little finger, then EDC to ring finger. Then before the middle finger is the EPL to the thumb, which goes around the eroded Lister's tubercle. Important to remember. Then the EDC to middle finger, and finally EDC and EI to the index finger. So let us see the options we have for tendon transfers. So if there's only one sort of tendon to the little finger, the EDMs and the EDCs, we can take all of them and do a side to side transfer to the intact EDC to ring finger. So that's one option. If the tendons to little and ring finger goes, then we can borrow extensor indices and transfer to both of them. We can even borrow a flexor tendon, is your choice. Then if the tendon to three fingers, little, ring, and middle goes, you can take extensor indices, give it to the extensor tendons to little and ring, and the extensor tendon to the middle, you can do a side to side transfer to extensor tendon to the index. Then, or you can take extensor indices to the middle finger and your choice, flexor tendon from the ring or the middle finger, and attach to the both. So you have 2-3 options. One is your extensor indices, which is expendable. Your flexors from ring or long fingers are expendable, or you can do a side to side transfer. So if your forefinger, all the fingers extensors have gone, you can take flexors from the front, from both the ring and middle, and one flexor goes to 2 index fingers. So remember 3 choices: flexor tendons, extensor indices tendon, and a simple side to side transfer or end to side transfer. So let's see a case. Final few slides. One of my case. This is how this patient came to me. 2 dropped fingers, lots of swelling there, and
make a fist for us.
So you can see he clearly can't extend these 2 fingers. So I said, okay, fine. After doing the workup that we have discussed, MDT approach, rheumatologist, hand therapist, occupational therapist, after liaising with all of them and assessing the patient, I decided to offer him a tendon transfer. Now to start with, as you can see my incision, little sort of mark on the index finger, I was planning to use the indices. But let's see what we did actually. So that's the sort of incision I do, a midline approach. That's the synovial swelling. This is localized purely to the tendons. Another swelling, synovial proliferation over DIUJ. So once I've opened, a lot of swelling there, and see with the suture I've held a ruptured distal end. So see, this is how synovial proliferation happens. And inside all this tenosynovitis, how tendon starts to rupture, how the collagenases erode or eat up all the type 1 collagen. So when I open this pouch, see, that's the proximal end, that's the distal end. So that's how rupture happens, encased in a synovial proliferation. So these are my 2 tendons. Well, more than 2, because little finger can have up to 2 to 4 EDMs. But yeah, these are the rupture tendons to the little finger and ring finger. But see what I didn't expect. Middle finger tendon was also very tatty. So if I had not gone in few weeks, this would have gone. Then I said, okay, let me have a look at the index finger. Again, this was starting to go. This is not a healthy looking tendon. That's the healthy tissue. This is the unhealthy tissue. So now when I saw this, and this guy is young, as you've seen, he's in early 50s. He does a lot of manual work. So I said, I'm not going to take extensor indices now because his EDC to index is also tatty. So I want, for him to have this thumb pinch, I want both his tendons there. So EI was not the option, at least in my books. I was also worried about the middle finger. It was not very healthy. So I thought, okay, I'm going to take 2 flexors from the front and let's see what I did. So flexor to the ring finger, that's A1 pulley. This is how I take it out. Incision just proximal to carpal tunnel. That's the middle finger. That's the flexor tendon to the middle finger. So once you've identified at the proximal end and at distal end, only then will you cut there and harvest the tendon. So I took out my 2 flexors from the ring and the middle, came proximal to the DIUJ through the intraosseous membrane, came on the dorsum. These are the 2 tendons. They have very good excursion. And then what I've done is 1 flexor tendon, I've done a wrap around to 2 EDMs and 1 EDC to the little finger. And then other flexor tendon, I have done a pulvotaft weave to the ring finger. And because middle finger tendon was also tatty, I've done a end to side transfer here. So that was my rationale for 2 flexor tendons. These are my 2 tendons to the index finger. Now 2 things here which you can be asked, how do I adjust tension? So if I flex the wrist to around 30 degrees, all the fingers should come out into extension. This is how I adjust my tension. Pulvotaft weave, this can be a question in itself. So basically, if this is my flexor and let's say that's my extensor tendon, so I'll, with a knife, you stab it, pass the tendon, put a knot, and then come at 90 degrees. So see this, so this was a stab at the side of the tendon. This is me stabbing or showing the stab at the top of the tendon. So you keep, so go at the 90 degree again, put a knot. At this stage, you check your tension. Is it enough? Because remember, post-operatively, there'll be some myostatic relaxation. So if you're happy with the tension, then you carry on with your weave because you need to have at least 4 weaves. So you've come from the top, this time you've gone from the side, so again 90 degrees. And this time you can stab at the bottom and come from bottom up. So you keep going at 90 degrees, basically. That's your pulvotaft weave. And then remember I was saying, I'll show you my bars procedure. So this was this drudge synovial swelling, which I've all taken out. Look at the sigmoid notch, grade 4. I put a wire to hold my ulnar head temporarily when I do my bars. Bars basically is I've made a big, nice capsular flap. Sometimes you can add retinaculum to it. And I'm going to take some stitches on the volar tissue, which is what I'm trying to show here. So stitches in the volar tissue and interpose this. So it's a soft tissue interposition arthroplasty, basically. So see how I'm going to take my flap inside. So grade 4 arthritis or sigmoid notch won't matter. So once more, the whole flap goes inside and I'll attach it to the volar. And X-ray shows what I've just said, grade 4 drudge away. So then, so once I had done this, then there was no extensor retinaculum also. See, drudge is all done now. So what I've done is taken a palmaris longus graft to reinforce my retinaculum. So to stop any bowstringing. And you can clearly see transfer here and a pulvotaft transfer there. So this was to stop any bowstringing. This is how it looked finally. So this is palmaris longus to reinforce retinaculum. And then this is how he...
Good morning, Mr. Agarwal. Welcome to Catford, South East London. Yeah, Tom. Yeah.
This is how his results was.
You got it close on it?
Down the line.
Okay.
So you can see, so we're talking about 3 fingers. Remember, middle finger with an intact tendon. So I'm not sort of worried about the extension part. But these were the 2 fingers where tendons had gone. So if you compare it to the middle finger or the index finger, maybe there's a 5-degree lag at the ring finger, maybe 10 degrees or 15 degrees at little finger. But see all his 4 fingers. He's not able to fully extend or hyperextend at any of those. Once
Show him where I can.
see. So on the whole, he was satisfied. And remember, I was saying patient needs and expectations. So it's patient who decides the success, basically. So overall, we were happy. And then extensor tendon rehabilitation. So remember, post-op edema pain control is important. Orthotic, protective orthotic positioning, very important. So that's where hand therapist comes. You need to give or make a customized orthosis, 2.5 months or 3 months or thereabouts. Then tendon transfer training. So 2 ways, either static immobilization, so in a plaster, or a orthosis for 6 weeks. Not a good idea because it creates a lot of adhesions and scarring and tendons being on glide. In terms of motion, either a dynamic mobilization, so this sort of a device where patient can actively flex, but this dynamic advice will passively extend the fingers. But again, as you can see, it's very cumbersome and patients tend not to like it. So in my practice, I prefer early active motion. So I write to my hand therapist on the day of surgery. I drop him or her an email saying what I've done, the procedure. And then remember, tendons are weak between post-op day 5 and day 10. So either you catch them before day 5 and start early active mobilization, i.e. active flexion, passive extension, and in between your orthotic, static orthosis. So which is what I prefer. And then of course, there's a tendon transfer, then functional training to get the function back in the hand. And these are my references. That's my website. On the menu bar, that's my YouTube channel. If you click on it, this is sort of page which opens up where I've done lots of lectures for consultants and for FRCSOrth examinees. Yeah, so thank you for your kind attention.
Thank you, Saurabh, for yet another wonderful presentation. Saurabh, you can switch on your video, please.
Yeah, I've done it. Perfect. Perfect.
Great, Saurabh. Saurabh, quite a good presentation and very exhaustive. I think the candidates don't need to know more than this.
Thank you.
Saurabh, I'll just stick on to two small questions because it has been a very long one. So can you explain me what was the role of a Sauber-Kapandji operation of the wrist in rheumatoid? Does it, I mean, we talk about Sauber-Kapandji elsewhere, right? So what about rheumatoid wrist?
Again, Darex and Sauber-Kapandji, I have almost never done in an osteoarthritic wrist. In a rheumatoid wrist, again, I've not done a Darex in years and years and years. I would do a bars procedure. But yes, especially I know, if I may humbly put it, in Indian setting, we're still doing Darex because I've done some operating here also in the subcontinent. Now with Sauber-Kapandji, if you come to think of it, it is like a proximal Darex because you're fusing the head to the sigmoid notch, to the arthritic sigmoid notch, and then you take off a centimeter of bone proximal to it. So it is even worse than Darex in my books because it's a proximal Darex. But yes, it is done very commonly here. I myself done a few in the settings here, especially with all sorts of drudge problems where patient can't afford expensive Adams type, and Yakimura type or Nakamura type. Sorry, I'm forgetting the name of, those tendon procedures. I think it's Nakamura. So Sauber-Kapandji effectively is you take the head, you fuse it to the sigmoid notch. So you take away that arthritis part, you take away that unstable drudge in case of chronic TFCC tears. But again, in my books, it's a proximal Darex with more impingement and more problems. But yes, if someone can't afford, you are in a village setting, one should do it.
And Saurabh, you mentioned about one of the problems with the Darex as well as the Sauber-Kapandji is the proximal ulna impinging on the radius and causing problem. Do you think looping a tendon through it reduces that problem? Saurabh, you're offline, I think. Yeah.
Sorry. So sorry, I couldn't hear your last two lines. I do apologize.
No, once you have done your distal resection, you have a proximal stump, right? So the stump is the reason for all the impingement on the radius, isn't it? And do you think passing one of the tendons through that will reduce movement and reduce impingement?
People have described those. People have even talked about, wrapping the ulnar stump with pronator quadratus. I've personally not done those. I'm not sure how the results are. But as I said, in some settings where patients can't afford costly, sophisticated procedure, it's a good option. I wouldn't do it in London.
Thank you, sir. And just one last question is regarding the wrist fusion that you mentioned. Now, what is the common procedure that you do? Is it a wrist arthroplasty or wrist arthrodesis for rheumatoid?
So you have to again assess the patient. You can offer both. If it's a bilateral rheumatoid, I'll fuse one, I'll replace one. That's 100%. If so, age is important. If someone is 25, I'll rather fuse it. Again, because it's an expensive implant, one can replace it at any age, with due respect. If the bones are very osteoporotic and I fear it means, so then I would not do a replacement. So you have to cater to the patient. One can replace at any age, but remember, it's something good. So with a very deformed wrist, very osteoporotic wrist, ligaments are not there, I would then rather fuse it.
And what about if there's a significant coexisting elbow or a shoulder disease? Would you do a replacement or a fusion?
Again, for shoulder in a rheumatoid, I would tend to drift towards a reverse shoulder.
No, on the wrist. No, it's coexisting shoulder and an elbow problem. Do you think a wrist fusion is contraindicated?
So you can replace both the shoulder and the elbow. I know that. But I have not come across a situation where I have to replace all the three, and I wouldn't. That's a lot of replacements in one arm. Then I can replace elbow and the shoulder, but I'll fuse the wrist.
You'll fuse the wrist. Okay.
I don't think 3 replacements patient to take.
Okay, Saurabh. Saurabh, I think that's all the questions that we have for the session. Thank you for yet another wonderful presentation, and really look forward for the next one.
Thank you, Hitesh, once again. Lovely to be on your platform, and good luck to all the guys preparing for this topic.
Bye-bye.
I hope it helps.
Bye-bye.